Welcome to CME 2020. Our topic today is in-depth evaluation of 3D RT-PS plan for oropharyngeal cancer. Here are our RT presenter. This is objective for our CME today. Without further ado, let's welcome our first presenter, Mr. Arif, to give you us an introduction.
Treatment plan system provide use volume histogram DVH for the PTV and each OIR eliminated, as well as the isolated curve over the whole treatment domain. The choice of the treatment plan is then usually made mainly by inspection of the DVH and isolated curve obtained for each tentative plan considered. Here, we discuss an IMRT, oropharyngeal case. We believe IMRT provide more advantages to this patient as the beams are modulated to the required intensity maps for delivering highly conforming doses of radiation to the treatment target while sparing the adjacent normal tissue. Besides, IMRT is the ideal treatment for oropharyngeal cancer as it allows periodic sparing to reduce the risk of xerostomia and obviate the need for matched electron field. In this treatment plan, it uses SAD technique for easy reproducibility.
Thanks, Mr. Arif. Now Ms. Kajang will tell you us about treatment planning.
Hi everyone, for this case, 6 MV photon energy with total dose of 70 gray is prescribed for this patient. Physicists planning the treatment will refer to International Commissions on Radiation Units and Measurements (ICRU) guidelines. ICRU volumes are standardized volume definitions used in radiation oncology practice that have evolved over time to account for advancement in technology and radiation planning. ICRU first published Report 29 in 1978. Report 50 completely supersedes and updates ICRU Report 29 with different volumes which need to be identified prior to any radiotherapy. These include the gross tumor volume (GTV), clinical target volume (CTV), and the planning target volume (PTV). ICRU Report 62 is a supplement to ICRU Report 50, which gives more detailed recommendations to account for anatomical and geometrical variations and uncertainties by introducing additional margin, which is internal target volume (ITV). In this case, GTV included the primary tumor and any limbs not over 10 mm in short axis dimension or smaller nodes that thought to contain tumor. A high-dose CTV 70 is created to include size of local and nodal spread. For this plan, we are not sure whether this patient has undergone phase 2 treatment. If yes, the plans for phase 1 and phase 2 should be reviewed together to ensure PDV are adequately covered according to ICRU 62 and critical structure are not overdosed. Acute side effect will be reduced if the dose to the oral cavity and pharynx outside the PDV is minimized. Based on ICRU report, dose should be within 95 to 107%. The total dose for this patient is 7,000 centigrade, so the maximum dose according to ICRU is 7,490 centigrade. However, in this case, the maximum dose is 7,731.8 centigrade. As sometimes it's a bit challenging to get ICRU protocol, oncologists have decided based on their knowledge and experience. The most important is that the hotspot is not for an organ areas, including the spinal cord. This is the outline of PDV and below is the outline for irradiation of nerves. Now, let's invite my colleague Ms. Damia to let you take a look of treatment planning algorithm, DICOM player.
Next, let's welcome Ms. Damia and Ms. Apirka to present on DDA.
By using a compiler, we can obtain important information such as the dose received by OIR. What is OIR? OIR stands for organ at risk. It can be classified into serial organ, parallel organ, and serial parallel organ. In serial organ, the damage at one point could lead to the damage of entire organ. Meanwhile, in parallel organ, the damage at one point, the other organ can still make up for the loss. In our case, the most OIR is in serial organ, except for vertical. The OIR in our case are lens, optic nerve, optic chiasm, eyes, brainstem, spinal cord, and vertical. Those received by OIR will also be analyzed through DVH, will be explained by my colleague. Physicists will go through the plan to see whether each OIR, to ensure that each OIR is not overdosed or underdosed. If either these two happen, they will need to replan the beam arrangement. Thank you.
Hi guys, so today I'll be talking about DVH, which is the dose volume histogram. It is a graphical representation of the dose delivered to any defined volume. So it is done to review the organ risk as well as the tumor volume. So each line on the graph represents a set of considered volume. So for example, the red line is the PTV, the blue line is the right eye, and the yellow line is the spinal cord. So from this graph, we can know each volume's minimum dose, maximum dose, and also the mean dose. It can also be used to identify whether any organ at risk has exceeded the tolerance dose. For example, we can take the spinal cord. Okay, so for the spinal cord, we can see that the maximum dose is around 4,100 centigrade, which is below the tolerance dose of 4,500 centigrade. So this table is a summary of all the tolerance dose of each organ at risk and also the dose they receive based on the age. So the concept of minimal tolerance dose, which is TD5/5, and maximum tolerance dose TD50/5, from the quantitative analysis of normal tissue effects in clinical setting, QuantSec, was applied to both parallel and whole organ that receive daily fractionation of 1.822 gray. Minimum tolerance dose represents the radiation dose that will produce 5% of risk in severe complications within 5 years after irradiation. Meanwhile, maximum tolerance dose represents the radiation dose that will cause a probability of 50% of severe complications within 5 years after irradiation. All organs have their own set of tolerance dose. For example, in our case, the optic structure, which involves the optic nerve, the optic chiasm, the lens, and the retina, are all within the acceptable range as the maximum dose is below their own respective tolerance dose. Meanwhile, for both brain and also the spinal cord, they are also within the acceptable range as their maximum dose are both below 45 gray and 54 gray respectively. However, for the parotid gland, both glands are not within the acceptable range. The maximum dose received by the right gland is 39.17 and for the left gland it's 58.39, which is way beyond the tolerance dose. There is a probability that the patient will suffer xerostomia within 5 years after irradiation. However, since the parotid gland is a parallel organ, even if one part is damaged, the other can compensate for it. So, what will happen if the other organs exceed the tolerance dose as well?
Finally, let's US proceed to side effect and its management.
It is important for RT to know dose received by each organ because each organ has specific tolerance dose. This is to spare the organ risks in the treatment area. RT should check if the PDB will receive an optimal dose to ensure the curative event is achieved. When tolerance dose is exceeded, this will usually cause side effect, either acute or late side effect. Acute side effects are usually seen within hours to days after exposure to radiation or within 3 months of completion of radiation treatment. Late side effects are usually seen after 3 months or even years after completion of radiation therapy. These are the examples of side effects that may occur. For xerostomia, usually we use drugs such as pilocarpine at a dose of 5 to 10 mg. For dental caries problem, conservative measures include pharmacologic convention, vitamin E and pentositylene, and hyperbaric oxygen HPO therapy. For optic or ocular neuropathy, systemic corticosteroids and HPO are recommended.
Thanks for all the presenter. Let's proceed to Q&A session.